right. Thank you for those fabulous talks. I'm delighted to introduce Dr. Staller and Dr. Rangan here for their Q&A session. We do have a number of questions, so I'm just going to jump right in. So Dr. Rangan, we'll start with you. So there are a number of people who are asking about, do you get EKGs, just as QTC intervals, on all patients before initiating TCAs or when you change doses?
Yeah, that's a really good question. I haven't been doing that routinely. I do it in patients with a documented history of QT prolongation. But unlike certain other medications that we prescribe in the GI setting, like erythromycin or domperidone and gastroparesis, I haven't been doing it routinely. But it's a good point that it's something to keep in mind.
Yeah, and
Okay.
I'll add to that. I also do not check a QTC for patients starting a TCA, except long QTC or someone who's on an SSRI already. Then sometimes I'll do it at baseline and maybe after a couple weeks.
Okay, very good. Thank you. Dr. Rangan, what is your maximum dosing of PEG and stimulant laxatives before you add or change treatments in IBS-C?
Yeah, that's another good question. Typically with PEG, I'll try and push the dose maybe to say 2 capsules per day. And I'll oftentimes try and do that in combination with either Dulcolax or Senna daily or sometimes or every other day and sometimes even daily. Um, with that said, I think the patient's perception kind of it kind of informs how quickly I'll switch to something else. If a patient feels like there's some incremental benefit, I might push the Miralax and stimulant combination a little more. If the patient really feels like there's been no benefit already and seems to be losing patience with it, then I may not even try pushing all the way and may pull the trigger a little bit sooner.
But you don't think there's a maximum dose that
Yeah, I don't have a fixed maximum dose. Usually if the patient's not responding to 2 capsules a day, I usually don't push them a whole lot further, but I do have patients anecdotally who have self up titrated even further than that. And if that dose works for them, I'm usually okay with continuing that.
Okay. All right. Dr. Starler, there are a couple questions on any association between POTS and Ehlers-Danlos syndrome with IBS.
Yeah, I mean, I think we know that in these populations who have connective tissue disease, whether it's labeled as joint hypermobility or Ehlers-Danlos syndrome or something along those things, often have a good degree of autonomic dysfunction, which POTS is one of those autonomic dysfunction diagnoses. We know that many of these patients have bowel disturbances. And so, for example, in a tertiary clinic in the UK, about 40% of individuals who were tested for joint hypermobility who were coming for tertiary level IBS care were positive for hypermobility. So something about connective tissue matrix in the gut, in the way that it affects nerve function, is super common. And I think especially at the tertiary level that Dr. Rangan and I see regularly, we are seeing these patients nonstop. And so I think there's definitely something there. The mechanism remains to be determined.
Okay, great. So Dr. Staller, so more often than not, when there is a lot of overlap symptoms when patients are seen. And so how do you differentiate between IBS, EPS, PDS, et cetera, and how do you then choose a treatment?
So, I mean, the real question is functional dyspepsia versus IBS. And I often tell patients that functional dyspepsia is really just IBS of the stomach, right? But the underlying malfunction here is a disorder of gut-brain interaction. It's the way that the brain and the gut are communicating with each other. So it's not uncommon for a patient who has IBS symptoms to often have functional dyspepsia and vice versa. And so those patients, although the FDA-approved treatments for, let's say, IBS may target diarrhea, constipation, you're not actually treating the functional dyspepsia. The neuromodulators, for example, the tricyclic antidepressants, you really could hit two birds with one stone, right? You could treat the functional dyspepsia and the IBS together. And so that's the way I think. I think there's a lot of overlap. And I always tell people that, there's really, these GI diseases do not respect anatomic boundaries, which means that the person who's going to have dyspepsia is very likely to have GI dysfunction elsewhere. It's very different than inflammatory bowel diseases where you're sort of rigidly stuck in one organ or another.
Right. Okay, great. Terrific. Dr. Rangan, do you ever add a TCA on someone with IBS who's already taking an SSRI?
That's a good question. I have actually. And, we would do things a little bit more cautiously that way. And, would probably want to be more cognizant of prolonging the QT interval in that case. But I have, just because SSRIs, there's not quite as much evidence for SSRIs specifically for treating IBS symptoms. And so in patients, a lot of times patients will be on SSRI for a different indication like anxiety and depression and may still have, poorly controlled pain symptoms or, perhaps diarrhea symptoms that haven't responded as well as we would like to medication. And so in that case, I will oftentimes try adding a low dose TCA in combination with that.
I think you're probably missing out if you don't, because as I told you from our study, there's a genetic overlap between anxiety, depression, and IBS. The same populations are prone to both, so you're very much likely going to see patients who are already on SSRIs. I'm not gun shy at all about adding TCAs to those patients, as Vikram said, with proper QT monitoring. But I think they can be some of the people who benefit the most. Just keep in mind that the SSRI is likely to push up the dose of the relative effective dose of the TCA. So at a lower dose, you're probably going to have a higher TCA exposure because of the metabolic interactions.
So Dr. Stoller, while we're on TCAs, what is the mechanism of action of TCAs in fecal incontinence? And is there one that you prefer?
Yeah, I think if you think of fecal incontinence as sort of two issues, right? One is dysfunction of the pelvic floor or the anal rectal unit, which tends to get worse in terms of aging, and is probably original damage is due to childbirth or other injuries. The other is that stool is delivered at a rapid rate to the rectum, and the anal rectal unit is unable to tolerate it because of the aforementioned decline over aging. So TCAs here don't really treat incontinence per se. What they do is they treat IBS that often underlies incontinence. And we know, although you would think that the biggest risk factor for incontinence is babies and whatnot, in reality, the biggest risk factor for incontinence is bowel disturbances. So if you treat the bowel disturbances with something like a tricyclic, then you're very much likely going to decrease incontinence or improve it altogether. My preferred go-to agent for a TCA is nortriptyline. It does not have nearly as much data as, let's say, amitriptyline, which has a recent Lancet trial. However, it is much less anticholinergic and tends to be well tolerated in these patients who tend to be sensitive to medications. So it is my go-to. Disipramine would be my second choice.
Okay, great. Thank you. Okay, so Dr. Rangan, a couple of questions about drugs and availability. So do you have insurance? How do you have insurance cover Motegrity, particularly when patients may have some gastroparesis?
Yeah, that's a good question, and unfortunately, I don't have a great answer for that. Sometimes insurance companies will make you jump through the hoops of first trying one of these more traditional first line prescription laxatives like Linzess or Amitiza, and sometimes in patients even who have gastroparesis and constipation, I'll have to first do a trial of one of those before being able to get approval for Motegrity. Sometimes where there's an opportunity to do a peer-to-peer, people actually are receptive to using Motegrity for combined gastroparesis and constipation. But yeah, unfortunately, I don't have a great answer. Sometimes, we just have to go through the motions of trying something else first. Yeah.
And just a quick question, is Zelnorm still available or not?
Yeah, so Zelnorm, unfortunately, it's not available. There's kind of this long history where, it was initially available decades ago, then went off the market, and then was reintroduced, I believe, in 2019, and unfortunately was removed from the market once again in 2022. I'm not aware of any immediate plans for it to come back onto the market, but yeah, I'm hopeful that that can potentially be a future option.
Okay, great, thank you. Dr. Stoller, there are a couple questions related to pelvic floor physiotherapy and biofeedback. So one question relates to, is there a role for pelvic floor therapy in fecal incontinence, and biofeedback is not available readily everywhere?
Yeah, I think this is one of the great controversies, if such a thing can exist in fecal incontinence, and that is to say that The people who really popularized pelvic floor treatment really were the biofeedback advocates. They did biofeedback, meaning a probe was inserted into the rectum and the patient could visibly see what's going on. Pelvic floor physical therapists really represent the mainstay of our providers out there in the community, including in Boston, who provide this type of treatment. And many of them do biofeedback as part of their treatment. But some of the best pelvic floor physical therapists don't do biofeedback, but they do internal work. So one way that you can judge, did your patient get true pelvic floor biofeedback equivalent physical therapy, is did they feel violated during their visit? Meaning if there was not a finger in their rectum and or vagina, then that was not real pelvic floor physical therapy. Many physical therapists that people go to do abdominal massage, and that's nice and it's comfortable. But at the end of the day, it's not really treating the underlying dysfunction. So if there was rectal work or vaginal work that was done, then I think you can, for the most part, consider that real deal pelvic floor physical therapy that's probably the equivalent of biofeedback, although there is not data directly comparing the two. Although Eric Shaw's paper recently looked at a large consortium of pelvic floor physical therapists in New Hampshire, rural Vermont, and found that in general, they were all doing very similar things, and those similar things seem to be very effective. So I think that I'm using pelvic floor physical therapy with biofeedback if available, but I leave it to the discretion of the provider.
Thank you. I think there's a slightly related question, which you may have answered already, is about if there are any data about who actually performs the feedback, whether it's a nurse or APP or someone trained in biofeedback or a true physical therapist.
Yeah, there's no direct comparative data. Like I said, I think my perspective is that physical therapists who do internal work are just as helpful as people who do biofeedback. Nurses can be trained to do this. There is some issues in the sense that recently Medicare said that a nurse can no longer do biofeedback unless under the supervision of a physician. And so some of the biofeedback models that have been in existence at academic medical centers are going to be under threat. So I think at the end of the day, physical therapy is still going to be the mainstay. As long as there is internal work, then I think you're getting a good quality product.
Okay. Dr. Rangan, how is peppermint oil prescribed?
Yes. So with the peppermint oil, we'll usually try prescribing that around meals. So typically we'll say to take peppermint oil a little bit before a meal, and that can sometimes lead to both improved bloating after the meal as well as reduced postprandial fecal urgency and abdominal symptoms. So a lot of times I'll recommend taking peppermint oil 3 times a day with meals. In patients in whom I'm a little bit concerned about possibly causing acid reflux, I might try, starting a little slower, like maybe with 1 or 2 of the bigger meals per day. But yeah, I would say 3 times a day with meals is a fairly standard way of utilizing it.
Okay. And a quick one here. What's the name of the app for self-CBT for IBS?
Yeah, that's a good question. There's one called Nerva that a couple of my patients have utilized and have had a good experience with. Um, I've I had a patient mention one other that I'm not recalling the name of.
Mahana is the FDA cleared one.
Yes.
And that's a prescription that you would provide, goes to a specialty pharmacy, and then patients generally paying about $200 out of pocket for the whole treatment. That one's FDA cleared. Nerva is gut hypnotherapy. Zemity is the other CBT. And then there's one more gut hypnotherapy app aside from Nerva that I can't remember. But so there's generally 4 major players, 2 CBT and 2 gut hypnotherapy. One of the CBTs is at Mahana is FDA cleared, and one of the gut hypnotherapy is FDA cleared as well. I can't remember which one of those, but they are very useful to not let perfect be the enemy of good, because it's so hard to find a live provider who can do this. The apps can be a nice surrogate.
Absolutely.
Dr. Sala, there's a question interesting here about nocturnal symptoms and patients who work the night shift, and whether there's, how you assess that, number one, but also, are there correlations with people who work the night shift and IBS?
Yeah, there are correlations. We do know that people who work night shifts are more susceptible to a variety of chronic diseases, IBS and bowel symptoms, including one of them. The way I would think of nocturnal symptoms is if a patient is working the night shift and they sleep during the day and it wakes them up from sleep during the day, that is the equivalent of a nocturnal symptom for a night shift worker. The question I always asked is more anecdotal than anything, is many IBS patients will wake up at night for another reason, because disordered sleep is part of IBS in many patients. And then once they wake up, then that urge to have a bowel movement or that pain will hit them. That I would not call a nocturnal symptom. What I would call a nocturnal symptom is someone who wakes up and immediately is running to the bathroom. Those are the patients where I'm thinking about more structural inflammatory disease, for example, microscopic colitis. But many IBS patients will sit and ruminate in their bed, having these poor sleep patterns, and then the abdominal pain will hit. Just because it's hitting at night, that's not the typical nocturnal thing I would think of.
And so this is this may be a little just sort of general. I don't know. So a patient who has abdominal pain and change bowel habits has been always billed as IBS. Like, at what point do you ever consider that they should have a colonoscopy?
Yeah, I can start. I'm sure both of us have a lot to say. So, there are a couple of typical risk factors. So, if there's rectal bleeding, if there's weight loss, if there's been kind of this abrupt change in bowel habit, all of those would be reasons for us to push for a colonoscopy. And then, our standard is always our threshold is always lower in an older patient as well. Particularly if there are any coexisting alarm symptoms as well. But I think in general, you can get a fairly good clinical gestalt, based on, the demographic that the patient falls under, the duration of symptoms that they've been having, and, how characteristic the symptoms are. You know, from personal experience, by the time patients reach us in our tertiary care centers, the majority probably have undergone some sort of endoscopic evaluation. But typically, I would say that without any of these red flag symptoms and with characteristic clinical symptoms of IBS, it usually is not necessary to rush them into a colonoscopy.
Yeah, I would agree. Alarm symptoms, obviously, it's easy. And IBS is right. It's a clinical criteria: abdominal pain, change in bowel habits. It leaves a lot of room. But a true IBS patient is a disorder of gut-brain interaction, which means they tend to be wired to be a sensitive soul from the get-go. So these patients, although they may not be seeing you from childhood or from adolescence or college, they've had symptoms or a sensitive stomach in one form or another for much of their life. And now they're showing up because those symptoms are bothersome for one reason or another. So in that patient, I think I can confidently make a diagnosis of IBS and avoid an endoscopic procedure. Now, someone who has never had any GI issues, never even thought about their stomach, and suddenly after the age of 50, they have classic IBS, I'm sending them for a procedure, right? You don't think of IBS as starting de novo after the age of 50, maybe post-infectious, but those are the patients where you really should say, they've never had anything before and suddenly they have something. I think your suspicion should be pretty high for something else going on.
Just a quick recap. Someone asked, can you repeat the names of those apps besides Nerva and Mahana? Or
Yes,
are those just the two?
Zemity and Mahana are the two CBT apps. And then I'm just trying to look on my computer here. Nerva is gut hypnotherapy. And I'm looking to see if I have the one other one, because everyone should have their due diligence. Do you have it there, Vikram?
I'm sorry, I'm looking as well. Sorry.
Okay, well, why don't I'll ask if while Kyle looks that up, Vikram, someone's asking here about approval for Celesta.
Celesta for IBS specifically?
No, for fecal incontinence, I assume the Celesta injections. It's not going to get approved. You can get it, but no one's going to pay you for it. So I think that's what functionally we talk about it, but it doesn't actually, realistically, it's not something that can be part of people's practice yet. And I don't anticipate it getting approved anytime soon. The other app is Regulora. So Regulora and Nerva are the gut hypnotherapy apps. The CBT apps are Mahana and Zemity. CBT, I think, best for people who feel like there is a stress-induced component of their symptoms. They recognize that brain-gut connection and the role that stress may doing in exacerbating their symptoms. Gut hypnotherapy, I think these are patients, again, who have to be willing to understand this brain-gut connection, but those who maybe have more somatic symptoms that cross the boundary, not just in IBS, but other things as well. That's what a GI psychologist once told me on how to figure out, what type of brain gut behavioral therapy you should use. That's sort of the CBT versus hypnotherapy. I have more experience with Mahana, but full disclosure, have also consulted for them and done some research using their data. So I'm kind of intimately familiar with it. But I think all these apps have really democratized IBS gut or brain gut behavioral therapies, which is exciting.
Someone sent in, is there another app, MetaMe? Is that one that you're aware of?
MetaMe, I've heard of. I think there's a lot of apps out there that have not necessarily undergone as rigorous of things. And some of them are just sort of wellness apps. And I even heard that Mahana will be sort of migrating more toward a wellness type platform, which is a shame because it's moving away from evidence-based treatments. I would say those big four are the ones that you should be thinking about that have actually, worked, that have evidence behind them, and people have tried to sort of rigorously evaluate their efficacy in one form or another.
Okay, great. Dr. Rangan, so we'll go back to a little bit about treatment. So I know you had commented on dosing for things like PEG. Someone's asking about things like other laxatives like magnesium oxide, milk of magnesia. Do you have guidance on how to dose it, and how much to dose for those?
That's a good question, just because there's so much variability in the potential doses of those. With the magnesium oxide, I tend to like the 500 milligram laxative formulation, and usually I'll try and get patients up to a dose of 3 of the capsules per day or 1.5 grams per day, just to give a fair trial for the magnesium oxide. Although a lot of times I'll start with a lower dose and kind of escalate from there. With milk of magnesia, I personally have less experience utilizing that as a first-line osmotic laxative. Typically, I've seen doses of 15 to 30 milliliters, 1 or 2 tablespoons on a daily basis. But as is the case with Miralax, there's quite a bit of variability, and in generally, I do think of it as a fairly safe medication since it's not something that's absorbed by the body. So I'm willing to let patients experiment a little bit on their own with the dose that works best.
Okay, great. Kyle, there's a question, just a technical thing about balloon expulsion tests. Do you use that for fecal incontinence? And how many mLs do you use to inflate the balloon?
So the balloon should have 50 milliliters of saline. That's the standard. I think it's less relevant balloon expulsion for fecal incontinence. It's really relevant in constipation. I think when it's relevant in fecal incontinence is those people who may have constipation and thus having incomplete evacuation, which is then leading to fecal incontinence. Those people, I think the balloon expulsion test is very relevant. But in general, I think fecal incontinence can benefit from some type of biofeedback therapy, but balloon expulsion or not.
Okay, super. So we're at the end of the time. So there is a comment here about Dr. Stoller's slides not being up there, and I will make sure they're uploaded. I don't know why that didn't get into the syllabus. Actually, it's Dr. Stellar that's there, which I think is appropriate. So
right,
anyway, I'd like to.
Right, Dan?
So I want to thank both Dr. Stoller, Dr. Rangan for a fantastic session. We'll go into our break, and we'll see you again at 3:40 for the final session of the day. So thank you.